Hi, my name is David Villar. Welcome to this video on the use of injectable anesthetics in veterinary medicine. You may see the abbreviation TIVA being used to refer to a general anesthesia in which we give everything parenterally, usually by the intravenous route without the use of gas anesthesia. And the whole rationale is basically it's many times impossible or impractical to provide anesthesia in a more sophisticated way. Having said this, it's probably more popular now than it was in the past because with the new anesthetic drugs like propofol combined with opioids and the use of infusion pumps, we can really allow for a target control administration. I have listed some of the most wanted properties of injectable anesthetics here. There are probably many more that are not included on this list, and I will not really spend any time talking about them here because, as you will see, we're going to describe some of the good and bad things about each type of anesthetic, and as you will see in the end, you can probably decide for yourself why it may be a better idea to choose one or another from the entire group available. I can say this that there is no perfect one that meets all the criteria of an ideal anesthetic. And we could, if we see which ones we're going to discuss, we could roughly divide them into those that are administered as an intravenous bolus administration, and those include the barbiturates and the phencyclidines, and those that are given as a continuous rate of infusion and for which you may need more sophistication, like having an infusion pump so that a control target dose can be administered. And this will include the propofol, Etomidate, and alfaxonone. Now we're going to start with barbiturates. This is probably the oldest category of central nervous system depressants in veterinary medicine, ranging from causing light sedation all the way to death, depending on the dose and the type of barbiturate. As you can see on this list, they can be classified according to the duration of action as short-acting, long-acting, and ultra-short-acting. Or you can also classify them according to the chemical side chain on that barbituric acid molecule, basically into oxybarbiturates and thiobarbiturates. The thiobarbiturates are more soluble in fat, and they tend to move in and out of the brain a lot quicker, which basically accounts for their ultra short activity. As you can see here, they bind to the GABA receptor in different parts of the brain, and they facilitate the action of this neurotransmitter, and that usually results in that resting membrane potential of the neurons moving away from the threshold of excitation. And basically, in other words, what that's doing to the neurons is they're putting them to sleep. Obviously, they will not be capable of firing any impulses. If we look at the medical applications of the three main types of barbiturates used in veterinary medicine, the ultra short-acting barbiturates are basically used to induce anesthesia. They're not very good to maintain it because if you continue giving additional doses, you will basically prolong recovery and the hangover that goes along with it. And the reason why animals awaken so quickly with thiopental could be explained by this phenomenon of redistribution away from the brain and not the metabolism or the biotransformation of the drug. Which is actually very slow with a half-life of about 10 to 12 hours, in which basically the liver is converting, or if you like, chewing up that drug into inactive metabolites. This is really very different to the metabolism of propofol that we will see is very quickly. And if we look at this graph at time 0, when the drug is 100% in the vein after you give a single dose, you can see that it tapers off very quickly because basically the drug moves into the vessel-rich organs like the brain. It reaches blood-brain equilibrium really quickly in just a matter of 30 seconds or between 30 and 1 minute after giving that injection. And so the reason why we awaken so quickly is because it leaves the brain just as quickly to move into muscle organs or lean tissues. and not because of the metabolism, as I just mentioned. And the fact that it's more lipid soluble than the other barbiturates explains why the onset of action is so quick, in just a matter of a few seconds. But as I have just mentioned, it's really short acting because this phenomenon of redistribution is taking it away from the brain. What happens if we continue giving multiple doses of that thiopental? We're basically going to saturate those lean tissues, and as you can see here, it also trickles into the fat, and basically that makes it a really poor choice as a drug for maintenance of anesthesia, because these other organs will eventually, when you stop giving it, it will leave these organs, and now the redistribution is going to take place in the opposite direction, that is basically into the brain. If we talk about the other drug, pentobarbital, you can see that the medical applications are different. It can be used to provide a longer lasting anesthesia between 1 and 2 hours. In the earlier days, this was really the anesthetic used routinely in dogs, but you have to be very, very cautious because the therapeutic index is really short, maybe 2 at the most. Compared with 7 for thiopental. So basically, this tells you that you can easily overdose and kill that animal. Now, today, as opposed to earlier days in veterinary medicine, pentobarbital is used primarily as a euthanasia agent, which makes it a class 2 controlled substance. Here you can see the label for Euthanex, which is the trade name given by one pharmaceutical agent in Colombia. And basically the indication is to provide humane euthanasia of dogs and cats. Now the other indication is to control or stop an animal from scissoring. And in fact, there are cases in which diazepam, which is usually the #1 option to stop convulsions, is not even going to touch those animals. And I'm thinking of sodium fluoroacetate, which is the infamous rat poison 1080, which is probably the most common rat poison affecting our pets in Colombia. And as I just mentioned, most of the times pentobarbital is really the agent of choice that most veterinarians will resort to. I invite you to watch the video on 1080 that is presented on the toxicology module, the VetMed Academy site, if you're interested to know more about this particular poison. And I'm briefly going to mention phenobarb, because this would really fall into the long-acting barbiturates. It's really weak compared with the previous two that I just mentioned. So you cannot really easily kill an animal no matter how much you're gonna give. Basically, it's really safe, and it's basically used to prevent an epileptic animal from having seizures. All the barbiturates except for phenobarb, as I just mentioned, are labeled for intravenous route only, and I emphasize the word only. They're usually painless unless they extravasate. In order to make them soluble, the pH has to be made really alkaline, of even more than 10, and that extreme alkaline pH will be very irritating to peripheral tissues and will cause a chemical necrosis. So you really need to make sure that everything goes into the vein, not even an artery. And if for any reason the drug extravasates, the first thing that you need to do is basically not panic. This may happen on the best families, so to speak, regardless of how good you are inserting your catheters. And in this case, we could say that the solution to pollution is dilution. So basically what you're going to do is infiltrate that area with saline at least 5 times the injected volume. And unless you do this, the next day that skin and underlying tissue is probably going to slough. Now, by this same reason, you cannot really mix barbiturates with any other drugs, or even with some type of electrolyte solutions like Ringer's lactate, because they will precipitate. So usually it's sterile water that is used as a diluent with the barbiturates. Now the next type of bolus injectables anesthetics are the ketamine and tiletamine, which are dissociative agents belonging to the phencyclidine family. Basically, they work by dissociating the thalamus from the limbic system. And as I just mentioned in the previous video, they don't really create a state of surgical anesthesia, which is necessary for surgery. So we're going to need to combine them with other drugs. I have listed some of the advantages and disadvantages here that are relevant from a clinical perspective. As I just said, they are not depressor drugs. Instead, they tend to stimulate the central nervous system. So, and the good thing is that they don't create hypotension or the depressive effects on the cardiovascular and respiratory systems as the other anesthetics. And that really makes them relatively safe compared with, for example, the barbiturates. So for patients that come in a state of shock or say with a hypovolemic situation, this would probably be a good choice of anesthetics. They can be given by the same syringe with sedatives if they are not already combined to begin with. And I'm thinking of tiletamine that usually comes along with solazepam in tilazole. And unlike the other anesthetics, these ones provide some somatic analgesia at doses that are even lower than the anesthetic ones. And in fact, ketamine is many times used in the postoperative period or for chronic pain syndromes at really low doses. As I just mentioned, it's not always feasible to give the drug by the intravenous route, and unlike the barbiturates, with these ones you can also provide them by the intramuscular route. And if we talk about the downside things of phencyclidines, the main one is obviously that will not move the animal to a stage 3 of surgical anesthesia. So it would be very, very unwise to perform any major surgery with only these drugs. The recovery from anesthesia is not going to be smooth, but all the opposite. Is usually going to be accompanied by excitement, hyperthermia. The animal is going to be fuzzy, cloudy. It's also mentioned in the literature. I'm not sure how often this may happen, but they can potentially create convulsions during the recovery state. We could basically call that these drugs are going to create a really bad hangover. People experience delirium as they wake up, which means that they feel hearing and seeing things that are not there, basically like if they were hallucinating. The other downside is that they're not advised to be used in patients with glaucoma or that may have an increased intracranial pressure, because it may worsen those situations. And it's also, just to mention, these drugs will increase muscle tone. They will induce purposeless muscle movements, which would obviously make it really difficult to carry out any procedure in the animal. And that's one reason why they should always be combined with other drugs that provide muscle relaxations like diazepam or psilocin. Finally, if we move into the anesthetics that need to be given by a continuous rate of infusion, there are three main ones. They all have in common to be very rapidly metabolized within minutes, I would say. They have what's called a perfusion limited metabolism, which means that the biotransformation is basically similar to the hepatic blood flow. So basically every molecule that gets into the liver gets chewed up right away, and it's not gonna come out of that liver. As you can already imagine, this is a good thing if you want to wake up quickly and with less hangover than the other anesthetics like ketamine or the barbiturates. In a dog with a normal circulatory time, all it takes for these drugs to reach the blood-brain equilibrium is about 30 seconds. Maybe for propofol it might be a little bit longer, 1 or 2 minutes. And what this means is that if you have not managed to induce anesthesia with the first dose given, you can administer the second dose after 30 seconds, and usually that's the interval that we're gonna choose between doses until the patient is in an adequate level of anesthesia. And that usually happens when there is no palpebral reflex and there are no chewing or yawning movements of the mouth. As I say, because propofol does not equilibrate so quickly, you may want to wait a little bit more between the doses just to make sure that you don't overdose that animal. Now, for the most part, we can say that that at least with propofol, the inductions are really quiet, smooth, without excitement, and regardless of the duration of anesthesia, the recovery is also going to be very rapid, without excitement, which is obviously a beneficial feature. There is one unique thing about Etomidate that makes it an ideal choice in patients with some type of cardiovascular disease or even a hypovolemic animal, and that is it doesn't depress the myocardial function or the sympathetic nervous system. So you may want to remember that of all the possible choices in a critically ill patient that is unstable with trauma, sepsia, this would probably be the safest drug. Having said this, nothing is really safe in a critically ill patient. And now, with propofol, people experience euphoria following the anesthesia. In other words, they feel really good afterwards, like if they had the best dreams ever. And this happens because propofol increases dopamine in the nucleus accumbens of the brain, basically the same as many other drugs of abuse. And in fact, propofol has potential for creating addiction and become a drug of abuse. They call it the Michael Jackson drug for a reason. So if you overdose it, it'll definitely put you to sleep forever. Now let's talk about the disadvantages of these drugs. None of these, and we can include the barbiturates also, block the autonomic responses to painful stimuli. And in fact, they even increase the sensitivity to somatic pain. So not only don't they provide any analgesia, but they create what's called a state of hyperalgesia. During the induction of the anesthesia, the main side effect with these drugs, just like with thiopental, is that they tend to produce apnea, which usually is of a very short duration, and it better be, but you should always be prepared to quickly intubate and ventilate that animal with pure oxygen, just in case. We could say that the short duration of action is either a good or a bad thing, depending on how you look at it. A shortcoming is that you need some degree of sophistication, ideally with an infusion pump, to maintain the constant inflow of the anesthetic. And a good thing would be that the recovery is going to be very fast when you stop giving either one of these drugs. So, and there are always things that should be known and taken into consideration that are unique to each one of these drugs. For example, just as we said with barbiturates that are formulated in a very alkaline pH to make them soluble, and this would make them very dangerous if they extravasate. With these other drugs, we need to know that propofol is formulated in an oil in water emulsion, basically with egg yolk, and that is a good, excellent medium for rapid bacterial growth. And so even if you refrigerate any unused propofol, it would probably be a better idea just to discard it, unless you come up with ways to prevent contamination, like mixing this 1% emulsion of propofol with 2.5% thiopental solution in a 1-to-1 ratio. And basically this mixture induces anesthesia in a similar way to either drug used alone. It's chemically stable for at least 1 week if you put it in the fridge. And because of the alkaline environment, it's not going to support bacterial growth. And finally, another diluent consideration, this time for Etomidate. To make it stable in water, it's formulated with propylene glycol at 35% by volume, and this raises the osmolarity of the solution, and that may even cause pain when it's given IV. It may even result in phlebitis or inflammation of those veins. So this is obviously a disadvantage for this one drug, apart from being the most expensive one of all the injectable ones that we just talked about. And finally, to wrap up the presentation, let's say a couple of words on protocols of administration. For example, with ketamine, the prescribed dose in a non-premedicated healthy dog is about 10 milligrams per kilogram, given together with zero 0.5 milligrams of diazepam. If you have premedicated that animal, you have to reduce the dose to 5 milligrams per kilogram. You don't administer everything at once with any of the anesthetics. Instead, what you do is you inject 1/4 of the calculated dose, and you wait for about 1 minute with ketamine. That's the usual interval between administrations until the patient basically is in an adequate level of anesthesia to either intubate or basically start the surgical procedure. If we talk about propofol, you basically do the same thing. A non-premedicated healthy dog, the dosage is 10 milligrams per kilogram. That's reduced to 4 milligrams per kilogram if you have premedicated the animal. And again, you administer 1/4 of that dose, wait for about 1 minute, and if more drug is needed, you give another quarter. As I said before, in a dog with a normal circulation, 30 seconds is the usual time between administration of doses, but with propofol and ketamine, as opposed to thiopental that reaches that blood-brain equilibrium a lot faster, you may want to wait a little bit more to prevent overdosing. And once the animal is in a surgical plane of anesthesia, you will need to maintain it. With propofol, it's usually done at a constant rate of infusion of 0.1 to 0.4 milligrams per kilogram per minute. Otherwise, you can probably do so with boluses of 1 milligram per kilogram every time that patient shows any signs of a light level of anesthesia. Having said this, I hope to have given you some good tidbits on the use of injectable anesthetics. I would like to at least point to a couple of good sources that I have used to prepare this presentation from the International Veterinary Information Service, and you can probably find most of the information necessary to perform injectable anesthesia in a safe manner with these types of anesthetics. So thanks again for listening, and bye bye for now.